While the DRC fights what may already be what is likely to become the largest Ebola outbreak in history, the US spent the week dismantling vaccines that work by executive order based on a feeling. This last week has been defined by one contrast. In Africa, healthcare workers are fighting a filovirus outbreak with tools that should have been built years ago. And new modeling says the true case count may be 4 to 5 times the official number. At home in the United States, however, a presidential executive order took vaccines that have worked for half a century and put them up for renegotiation. Not because the science changed, not because the epidemiology changed, but because a politician had a, quote, feeling. Feelings are not tools of cognition. But this week, they are trying to become federal vaccine policy. And Pennsylvania, my home state of all places, is showing us what that policy can lead to. I'm going to start with the presidential vaccine executive order. So what did they offer as rationale for this? The first thing was, a quote unquote scientific case that there were just too many shots. There is no criteria for too many shots, too few shots. It is really something that's derived from the epidemiology of infectious disease and the risk conferred. And importantly, you determine what the correct number of shots are for a given individual in a given time based on science, not based on feeling. Remember, human immune systems evolved on Earth, a planet that teems with microorganisms, and every day, even a newborn baby handles a far higher antigenic load than even the most aggressive childhood schedule delivers. The signing ceremony showed just how kind of far the discourse level has fallen, where you saw the president claim that babies are injected with a soda bottle's worth of fluid, which obviously is not true.
At 1 year, you should have 5 separate visits for vaccines rather than getting them all in the same day. And I saw this early on, and I've seen proof of it, where they have a vaccination thing, looks like the size of a bottle of soda, poured into a little child's body, and bad things happen in too many cases, because this is an explosion. This is an epidemic.
And that was flagged by Jake Scott, the infectious disease physician, in a SIDRAP op-ed. And then the president talked about, quote unquote, lethal effects. And when he was pushed for enumeration of the lethal effects of MMR, the president conceded that he didn't have a scientific basis. He just said it. And I think that this is really where the problem lies, that someone's emotions, someone's feelings are elevated to policy for everyone else. And this, to me, was a brazen act of political pandering that basically codified anti-vaccine disinformation, much of it which is nihilistic, into a presidential executive order, and was a big win for RFK Jr. There's also the feasibility case. So Merck, which is a major manufacturer of the MMR, said it might take a decade to relicense the monovalent, the single version components of measles, mumps, and rubella. And they haven't been made in the United States or haven't been marketed in the United States since 2008. And the claim that other countries use the monovalent measles is basically false. One country that does is Afghanistan. Why? Because they want to vaccinate earlier than they could with the MMR, because measles is endemic there. So they will use a monovalent measles vaccine to get to children earlier to protect them, because we wait till 12 to 15 months for the MMR, and maybe at 6 months you can use the monovalent measles vaccine. That might be something we have to contend with too as measles becomes endemic. Remember also that vaccines are money losers. This isn't something that companies like to get engaged in because their return on investment is low compared to a cancer drug or a cholesterol drug. Now you're making it even more inhospitable because you're dealing with dictates from the government coming from feelings. Pfizer is one of the most shorted vaccine stocks or shorted biotech stocks right now as its COVID vaccine revenue collapses. No manufacturer has a scientific or financial reason to split the MMR. And as I said, the government dictating that it's something that they should be doing is only going to make the matter worse. The other thing is that there's this paradox. Remember, they said too many shots. But if you split the MMR into its component pieces, you go from 1 shot to 3 shots with separate appointments, which is obviously going to lead to missed doses. And that was really emphasized in an op-ed and staff by Katrina Wallace. And we don't really need to just speculate. In Japan, they split the MMR because of an issue with the mumps component of the vaccine, and they made mumps kind of an optional vaccine and made a bivalent measles rubella vaccine. What happened? Recurring mumps outbreaks in Japan, meaning people weren't getting the other component of it. That's what will happen here. The other issue, and this was pointed out by one of my colleagues in Allegheny County at the Allegheny County Health Department, Dr. Jillian Irwin, the rhetoric might cause parents to hold out for a hypothetical monovalent measles vaccine that is not coming when there is something that actually is here already that works, the MMR vaccine. I also wanted to make a comment about Denmark because people keep bringing it up as a comparator country. No one's ever asking whether Denmark's schedule is good. Is it good for their own children in Denmark? They don't vaccinate against rotavirus, but yet they get over 1,000 rotavirus hospitalizations every year in Denmark. Is that a good thing for the Danish children to be hospitalized for rotavirus? I'd say no, it's not. It's objectively not good. So I don't think that Denmark is someone to compare against because they are putting their children in unnecessary harm by not vaccinating against things like rotavirus and causing preventable hospitalization. The other point I want to make here is, where is the CDC director? Erica Schwartz has been sworn in and she said nothing. This is a time for her to actually show that she is a physician, that she stands with Louis Pasteur and not with RFK Jr. She once said that the president and the HHS secretary would never ask her to do anything unscientific. I think that's happening now. They're asking her to go along with this, clearly because she hasn't opposed it. Her predecessor, Susan Menarez, was fired for speaking up for the science. Susan Menarez's former CDC colleagues, Dimitri Daskalakis, who was the head of the National Center for Immunization and Respiratory Disease, who courageously and heroically quit in the wake of Susan Menarez's firing, had said that the honest move was to decline the job, and that it's hard to know how anyone can be CDC director inside an RFK-controlled HHS. That's definitely the case. I agree with Dr. Daskalakis. She shouldn't have taken this job. No legitimate infectious disease physician or any kind of physician should take the CDC director jobs. And thankfully, 30 states are saying they're basically not going to follow federal recommendations. Hopefully, we get that up to 50. And then, just a contrast, and Matthew Herper wrote about this in Stat. There is a great scientist named Maurice Heilmann who died several years ago, and he's one of the greatest vaccine scientists that have ever lived. He is basically the father of many of our childhood vaccinations. He worked at Merck, and Matthew Herper in that piece talked about the ghost of Heilmann haunting some of the members in this administration. And there's the contrast. You've got one man who spent his life advancing civilization against infectious disease in the form of Maurice Heilmann, and now you have the government voluntarily, actively saying, we want a lower standard of living. We want civilization to go backwards. And that's my take on the vaccine executive order. So when you think about the vaccine executive order, it's obviously going to lead to implications. And I thought I would mention a little bit about measles, particularly since it's now affecting my home state. And my home state is one of the hotspots, accounting for the majority of new cases that are being added each week. Overall, we're over 2,500 cases, and Pennsylvania is around closing in on 300, which is a record year not seen since the 1990s. And a lot of it is centered around Lancaster County in the center of the state. That's important because, yes, Lancaster County is the home of the Amish, and they tend to have lower vaccination rates, not completely, not universally, but in general, yes. But about 5 years ago, RFK Jr. brought his anti-vaccine advocacy to Lancaster County in person. He's telling a population's already vaccine reluctant that measles isn't a big deal, chicken soup treats it, that the vaccine doesn't have value. And while you can't say that the visit actually caused this outbreak, it's rhetoric like that emboldens doubt in exactly the people who are already predisposed to it. And what are the consequences of measles? People keep saying deaths, but there are lots of bad things that can happen short of deaths, including hospitalizations, including ICU stays. And there was an op-ed in MedPage today by Robert Shippen, a UCLA critical care physician, who basically said ICU doctors are going to be charged with seeing the end stage of the anti-vaccine movement: severe measles, severe influenza, liver failure from hepatitis B. That's going to be, in the future, if it doesn't change, if people don't heed the ghost of Maurice Heilmann, that's the future, is that you have preventable ICU admissions that happen in ICUs that are often capacity strained to begin with. And these downstream consequences, they're not really part of the political calculus. Politicians always privilege the short term over the long term because in the long term, they're not going to be in office. It's somebody else's problem. So what they're seeing is they've got this benefit to be anti-vax right now, that there's political power, the anti-vaccine movement, RFK Jr.'s masses will support them. And the bill will come due after they have left office. So they don't even think about the long-term consequences. They are saying, does this get me votes today? Does this get me donations today? Does this get more people to come to my rallies? Does this keep me in office? Does the anti-vaccine movement offer me value today to stay in office? And that's the calculation they use. Not, is this correct? Is this what science and medicine would say is the best policy? Am I thinking about all the consequences, all the trade-offs? No, they don't. They don't care. And on the current trajectory, measles will become endemic in the United States again, 2 decades after we eliminated it. I want to now talk about Ebola. And there's a lot of modeling that's been coming out suggesting that the DRC outbreak is likely to become the #1 Ebola outbreak in terms of case count in history. We are doing lots of work with vaccines, and that's great, but a lot of these questions should have been answered not in the midst of an outbreak. When you look at this outbreak, one of the things that has driven it is the fact that it was spreading for weeks or months before anyone noticed. Now there's genomics data saying that this probably spread from at least mid-February. There's anthropological data saying maybe January, but the genomics data say around mid-February. And it seems to be consistent with the fresh animal spillover. So maybe that was a bat, maybe that was a gorilla, maybe that was an antelope, some bushmeat, or whatever it might have been. This is only the 3rd recorded Bundibugyo outbreak, and it doesn't seem to be related to the other 2 in terms of genomics. Contact tracing, which is the mainstay of how people deal with Ebola outbreaks by isolating contacts and monitoring them for symptoms so that they don't spread it to anybody else when they become symptomatic, that's failing. So now teams are going door to door, and you're going to see case counts rise as they expectedly find more cases. Ituri province seems to be the hardest hit by a long margin, 90% of cases, 80% of deaths there. And there are task forces now that are forming to get the community involved to protect healthcare workers, and some of the pro-government militia groups are participating. So that might help with some of the problems we're seeing go on there. I've talked about the fact that the Merck vaccine against the Zaire species of Ebola, which was successful in prior outbreaks when Ebola was being caused by that species, there's some anecdotal evidence, there's biological plausibility that there is cross-protection against the Bundibugyo species. So now a phase 3 trial is starting there using individual randomization rather than ring vaccination randomization, which before they would randomize rings of contacts to the vaccine or placebo. Now they're going to do it individually. This is going to give us a readout probably pretty quickly to see how much that protection lasts. And I think this is a great thing. But another op-ed that I read by an infectious disease physician, Krutika Kapali, and then also joined with Placide Mabala and STAT, made the argument that I've made before, that we've needed pan-filovirus, pan-Ebola virus countermeasures for a long time. And this cross-protection question itself should likely have been worked out in the past, even though there was some work done. This is not something that we should be trying to learn in wartime. This should have been something that was done proactively because we knew that it wasn't just Ebola Zaire that posed a threat. There's Ebola Sudan, and there's also Marburg, another filovirus that really don't have any countermeasures. The U.S. continues to enforce irrational travel bans, and they're actually expanding them. Now, if an American merely connects through Uganda and South Sudan, and remember, Uganda and South Sudan do not have Ebola cases, they get treated as if they came from the outbreak zone. They get funneled. They don't have to do the 21-day quarantine in Kenya, but they're getting funneled and treated that way, which just really disrupts aid workers, disrupts the entire region, and it protects no one except for short-term political interests that basically don't actually understand the transmission characteristics of Ebola. I wanted to talk now a little bit about the foodborne outbreaks that are going. These are taking a lot of headline space. We've got Cyclospora and Salmonella dominating the summer, and I don't think I go a day before someone asks me, can we eat lettuce? So this is something that's really live in people's minds. So right now we have the Cyclospora outbreak in 17 states. Maine and Massachusetts are added, but it does seem to be cresting in terms of the Taylor Farms shredded lettuce. It's hitting its best buy date. It's probably aging off the market. People are throwing it in the trash can. And the FDA has finally sent investigators to the Mexican processing plant to see what happened there. That's Cyclospora, and there's more outbreaks than just the Taylor Farms outbreak. Salmonella, there is a jalapeno outbreak linked to importation from Sinaloa, Mexico, which has affected Chipotle, Qdoba, Sweet Greens, now Whole Foods prepared products. And you also have a separate outbreak of salmonella related to eggs tied to Midwest poultry. And that's been escalated to a Class 1 recall, which is the FDA's highest level. Class 1 means that FDA has judged that there's a reasonable possibility of serious health consequences. So that's the latest on the egg outbreak. With Cyclospora, another important development is that Roche, the diagnostic company, has built some research-only PCR tests for Cyclospora. They're not commercialized, but that will help. Right now, most of the testing is not done using PCR molecular diagnostics, with some exceptions. The BioFire test does test for Cyclospora, but many hospitals don't use that version. So it is something that's cumbersome. So you expect a long tail because, number one, testing is going to lag symptoms, and then testing is going to take some time for it to come back and be added to the case tally. There are people who will still get symptoms after they've been treated as well. That's important to keep in mind. So this is going to have a long tail with Cyclospora. Some people, all the oocysts aren't completely eradicated. Some people don't finish their antibiotic courses. Some people get irritable bowel syndrome after these types of infections. So that's all going to be something we contend with in the future. Some people ask about why this happens in summer. There's lots of reasons why it might happen in summer in terms of the growing season for certain foods. But one other thing is that outdoor cooking creates an opportunity for food to be left out. The supply chains are going to be warmer when you're transporting food, and bacteria like to grow at warmer temperatures. It's harder to keep things cold. The New York Times had an interesting article talking about, and this is answering a question that I got asked as recently as yesterday, when can we eat lettuce again? While the Taylor Farms issue is likely over, there's a larger point it's made in this New York Times article that nothing in life is risk-free, that each person's risk tolerance is going to legitimately differ. That's why it's all about harm reduction. So if you can peel the skin off of a piece of produce or remove some leaves off of lettuce, that's going to decrease your risk, not to zero, but it helps you manage that risk. But zero risk is never going to be something on the menu. Moving now to respiratory season. There's been some updates with flu and RSV prevention and a little bit about COVID. Influenza vaccine, there's a couple of misnomers I want to address first. One is that blocking infection is the primary value. That would be great if our flu vaccines were able to block infections durably, that we didn't have mismatches, but that's not the case. The key value of the flu vaccine is prevention against hospitalization, prevention against emergency department visits, prevention against urgent care visits, and that's where the vaccine really does well. The latest data shows in children 51% efficacy against hospitalization, 54% efficacy against emergency department and urgent care visits. In adults, 43 and 45%. Remember, the vaccine's job is keeping you out of the hospital, and it does that pretty well. And if it prevents you from getting infected, that's kind of an added bonus. We will eventually get better vaccines that might have all of those features, but the current flu vaccines really are keyed in on protecting against severe disease. The other thing with flu is we have antivirals like oseltamivir or Tamiflu, and some people don't give it to people because they think, oh, the symptoms have been present for too long, but that doesn't apply if a person is getting hospitalized. Looking at real-world data in children who are hospitalized and saying, does giving a child oseltamivir, even outside of that 48 to 72-hour window, does it decrease their complication rate? Does it decrease their need to be in the ICU? The answer is yes. So the overarching point is, if somebody is being hospitalized, don't think about that 48 to 72-hour window from symptoms. That applies to healthy outpatients, not to someone being hospitalized. So antiviral therapy is really important for flu, especially when someone is immunocompromised or someone is being hospitalized. A little bit about the Moderna mRNA flu vaccine. So this is one of the flu vaccines that I think might be better, and there's data to support that. One of the advantages for it in the seasonal market, the platform story really here is speed. That if it takes 6 months for us to make an egg-based vaccine, which will mean earlier strain selection, more mismatches, less pandemic readiness, having something that can give you a vaccine in 2 to 3 months means you can select the strain seasonally later, which means less mismatches, which means more pandemic readiness if you have to make something new. And there is data coming from Washington University in St. Louis suggesting that the antibodies generated from the Moderna mRNA flu vaccine may be broader than the strains targeted. So it might protect more than what's actually in the vial, which will be very interesting to see in a follow-up study. A little bit about RSV. So remember, with RSV, the vaccine is something we give to older adults, and we also give to pregnant women who then pass the antibodies through their placenta to the developing fetus. So new data coming from Lancet Child and Adolescent Health in an English cohort that were vaccinated at 28 to 31 weeks, 76% effective against infant RSV hospitalization in the first 3 months after birth, and then 61% over the 6th, reflecting the fact that transplacental antibody is going to wane exactly as expected. So that's working very well. Nirsevimab, which is one of the monoclonal antibodies that we give to babies after they're born to protect them against RSV, really in major studies now, they're starting to show that this is confined to the first year, which makes sense, about how the antibody might wane. Do we need to redose high-risk children for the second year? That's an open question. But one of the other things it does is it decreases antibiotic use because clinicians stop hedging when they know RSV is kind of off the table in these infants. So they have a 14% reduction in outpatient antibiotic use. So there is this cascading impact. I wanted to mention a little bit about COVID because it's back in the headlines. We're starting to see a summer uptick in the South and West parts of the United States, but at very low levels. Less than 1% of emergency department visits are from COVID. Remember, with COVID, we've got two peaks. You've got this winter peak and we have this summer peak. And COVID is kind of odd in terms of respiratory viruses for having this summer peak. And we're not quite sure exactly why that is. There's lots of reasons to think and speculate about. But it seems that the summer peak is now getting bigger than the winter peak. That's really odd. But we'll see. There's some data coming from Los Angeles and places like that they're seeing more cases in the summer than in the winter, which is kind of a flip. But yes, we do have summer colds and summer respiratory viruses. So I don't know if that's happening with COVID. COVID is a coronavirus, and coronaviruses really have this stark seasonality that's in the winter months, but this still seems to be a little bit odd. There was some news on long COVID, and it was in a preprint, so not yet peer-reviewed, and Bloomberg reported on it, talking about in long COVID, they were looking in the GI tract of individuals with long COVID, and 27% of them showed genetic material of SARS-CoV-2. Remember, genetic material isn't viable virus, but it does show that there's some kind of signal here that needs to be followed up on. It's only 27%, so it's not everybody. And there was signs of immune activation there. So this will be interesting to see what happens when it goes through peer review. Remdesivir, workhorse antiviral for inpatients with COVID, so hospitalized patients. New study in looking at kidney transplant patients. And one of the things when you have a transplant patient is to not have anything cause the organ to reject. 47% less risk of graft loss or transplanted kidney loss in individuals who got remdesivir. So very valuable in the kidney transplant population. And there was another study looking at the vaccine in King County, Seattle, during kind of the height, February to September of 2021. Looking at the data there, it looks like the vaccine prevented roughly 4,000 deaths and 16,000 hospitalizations just in one county. And I think that's really important. That's what the vaccine did. It lifted that pressure. 16,000 hospitalizations prevented. Think about how much pressure gets eased off of a healthcare system if you can avert those hospitalizations when you're already struggling with capacity issues. There was also an interesting study looking at hip replacement surgeries within a month after COVID diagnosis. They were more likely to have sepsis and pulmonary embolisms than if you waited after that 4 weeks. So maybe delay elective surgery like hip replacement for a month after a COVID diagnosis to avoid those complications. Lastly, I just wanted to mention something about an animal disease that's in the news. It's called Bluetongue virus disease, and this is a disease of ruminants, so sheep and other types of animals like that. It is present in the United States, but there is an outbreak going on in the United Kingdom in places like Devon and in Cornwall, and there's about 400 or so farms in England that have Bluetongue, which might have implications for cattle movement importation. And this is something that we vaccinate for in animals, and as I said, there are certain serotypes of it that are in the United States. And why is it called Bluetongue? It causes cyanosis of the tongue, so that's decreased oxygen, so the tongue turns blue. And they talk about the 3 Fs: fever, face, the tongue, and feet. They can have feet lesions too on these ruminants. It doesn't affect humans, but it is an important animal pathogen to keep in mind. Spread by a virus. They get it through the bites of midges. So that's just something that you might see when it comes to a One Health perspective. Lastly, I just kind of wanted to sum up what we're seeing here. And I think that the larger story here is that we have multiple infectious disease threats that we're facing. Technology is working well to try and meet those threats. But then you have our policymakers changing the way we use that technology based on feeling and brazenly saying that they don't have scientific evidence for doing it. It's just a feeling. That's a recipe for the dark ages. And that's why I think it's so important to keep abreast of what's going on with the infectious disease world, because there are solutions available to master these problems and minimize the disruption on humans' lives. However, what we don't have are policymakers and politicians that are up to the task because their incentives are not aligned. They don't actually recognize what a driving force for advancing civilization, the control of infectious disease, is.